Hello, everyone. This is Josh from SIBO Survivor, and I'm super excited to have a chance to sit down and chat with Dr. Jason Hawrelak. He's an amazing naturopath and gastrointestinal consultant. He's considered one of the leading experts in the treatment of gastrointestinal conditions with natural medicines. And his passion lies in gastrointestinal health, the microbiota, and probiotics. So he has and the reason I wanted to kind of bring him on and just chat with him and help you guys out as well to learn is because he specializes a little bit in probiotics and prebiotics in gastrointestinal disorders like IBS and SIBO. So I'm just super excited to kind of sit down and get to learn from him and be able to look at probiotics and prebiotics in a different way to where you're educated and you can make a wise choice about, maybe trialing one or talking to your doctor about, doing it in the right and correct fashion. So, hey, Dr. Hawrelak. And so for anyone who doesn't know you, can you just give us a little brief introduction of yourself and maybe why you got interested in, microbial treatments for these disorders?
Okay. Hello, Josh. Yeah, I can do that. You're right. I'm a naturopathic clinician, and I finished my training back in 1999. So I've been in clinical practice for 18 years, and so I've been in practice either part-time or full-time. So quotas of that, but initially it was part-time. So I did my honors degree and then my PhD, looking at essentially the potential role of probiotics, prebiotics, and herbal medicines in the treatment of IBS, and specifically through the modification of the microbiota. So I started on that research project back in 2000, and then did my honors degree in Australia. It's a research-based honors, so I actually did a human clinical trial, and that was followed up by a few years as part of my PhD research too. So I was lucky enough to get involved with this area way before it was all that popular, and when there's more of a handful of researchers around the world who were passionate gut microbiota researchers. Yeah, and at that point, it was pretty easy to keep on top of all the literature that was coming out. But for me, as a graduate naturopath, getting a chance to delve deep into that area was just brilliant because, yes, we covered, prebiotics and probiotics to some degree as part of my naturopathic training, and certainly far more than you'd get in conventional medical training, for example. But really, it was just scratching the surface compared to the amount of research that was there. And just getting that chance to deep dive was absolutely brilliant. And I've been sort of deep diving ever since. And lucky enough to be able to engage with the research, and then actually, because I see patients too that whole time, I can actually read a research study that uses a probiotic or novel prebiotic, for example, for an application I haven't tried out before, and then actually give it a try on patients who have the same sort of condition or who fit that criteria too. So it's been a pretty amazing space to be in to be able to see things work firsthand too, because I do think that sometimes what we see in research doesn't always pan out in the real world, and it's nice to have a foot in both camps, so you can be very fluent with the research, but also see whether it works in reality.
Yeah, very fascinating. It's so cool how you kind of been in it before it got hot, right, so to say, and really had a chance to deep dive and learn about the effective use of these in IBS and other disorders. So I guess to start off with, a lot of people there's a lot of different ideas being thrown around about probiotics being used in SIBO and IBS. So from your experience, can probiotics be helpful for people with IBS and SIBO, and in particular, SIBO? Because I know that there's, some doctors discuss the idea of, with the motility issue, and some doctors don't recommend it. So I guess from your experience, have you seen that these are helpful?
Yeah, and I suppose I can speak again from both perspectives. And I was, as I said, looking at irritable bowel syndrome specifically back in my early research days and using probiotics in that condition. And so I'm familiar with the research as part of my literature review I did for my PhD thesis, was reviewing all the data that was there from the 1950s onwards. And we have consistent positive data on the role of probiotics in the treatment of IBS, very consistent from the 1950s until even recently, where there's systematic reviews being published every year or two, essentially saying very similar things, that probiotics as a class of agents have efficacy for the treatment of IBS and reduction of symptoms.
Yeah.
So for me, when this idea, the diagnosis of SIBO started becoming more popular, and at the same time they were saying that you can't use probiotics for SIBO, but then SIBO is also the cause of IBS, it just never computed for me, because I know the research on IBS with probiotics. They say that it works consistently. And if this condition is truly the cause of IBS, or at the time, I think there are people saying that 84% of people with IBS had SIBO as a driver, then it makes sense that probiotics are going to be helpful. So I suppose I came into it with a slightly different viewpoint. And also, I mean, the research is very consistent. Even if you look at the research of probiotics, we touched on how consistent the data isn't with IBS, but the data is very consistent in SIBO as well. That there was a systematic review published last year, and for those of your listeners who aren't familiar with systematic reviews, it's essentially you do a search of the medical literature and you find every single study that's been done looking at probiotics and SIBO, and you gather that data together and see if there's a pattern that you can discern there. What's the pattern? Well, in that systematic review that was done just last year, they found that I think it was a pooled decontamination rate, so SIBO eradication rate with probiotics is 63%.
Wow.
That's a very good outcome.
Yeah.
There's a reduction of hydrogen breath gases of, I think, 36 parts per million across the board with probiotics, and significantly reduced abdominal pain. So very consistently positive outcomes in SIBO with the field of probiotics. And I think really part of the issue is for some of the people that were the initial drivers of the SIBO diagnosis had ties in with pharmaceutical companies. And I think we shouldn't forget that the potential role that industry has on trends. And this was one of those areas in the literature where I think industry was a driver for dissemination of information saying that probiotics weren't going to be useful, despite the fact that data set shows otherwise. So if, because they're a direct competitor. So you've got this you're working for a company that provides the antibiotics to treat this condition. Well, you might give a different view of the probiotic literature than if you weren't having that sort of background. And I think that comes through because, as I said, the research has, even in the SIBO arena, has been consistently clear on the potential efficacy of probiotics for this condition.
Yeah, so the bottom line is there's been consistent evidence, and you've also seen in clinical practice the benefits of using probiotics.
Yeah. So I've talked about the research, and you're right, I haven't talked so much about my clinical experience, but I use probiotics and usually prebiotics in my IBS and SIBO patients consistently. I have for IBS for 18 years, or SIBO less than that, but they're consistent parts of my treatment approach, and I do get consistently generally very good results. Not every patient is different, and sometimes you get, particularly these days, some very, very challenging patients have failed with for years with lots of different treatment approaches. But in general, the approach of using the right prebiotics and the right probiotics, we're talking specifically about probiotics here, but the right probiotics can actually make a difference. And I think it's an area of treatment that many practitioners are shared to go down, and patients are too, because of that information, and I would call it mostly misinformation out there on the blogosphere. Now, there are individual patients that do react to certain substances. I see that too in my practice, but it doesn't mean that because a small percentage of people don't tolerate one or two things, that we shouldn't use that whole class of tools for every other patient, most of which will tolerate them fine.
Yeah,
and be useful therapeutic tools.
Definitely. So I guess the only other question going off of this topic is just that, I guess the idea out there that some doctors have is that, if you have a motility disorder and you put probiotics in, then, if that function's not working correctly, right, you're not sweeping bacteria down and it's building up. So you said that, there are patients that do have a tough time. So I'm just curious, do you see patients that, don't find benefit using probiotics, or is it really just based on the strain and the way that you prescribe them?
I think it's mostly based around that, to be honest, that I do think that if you choose the right strain for the action that you're after, then they generally are well tolerated. And sometimes it's excipients or binders in products that you have to be aware of too. Like some products might have xylitol or small amounts of fruit oligosaccharides, etc., that the patient might be reacting to, not to the probiotic per se. But I think as a class of agents, we know that probiotics have, they might work as an antimicrobial. And hence the data set I shared before, 63% decontamination rate, eradication rate We're essentially using the probiotics as antimicrobials instead of using antibiotics. Probiotics can work as prokinetics, they can work as anti-inflammatory agents, and they can work as gut healing agents, even idea of the range of actions that different strains may actually have. So for me as a clinician, I'm just trying to use the right strain that has that right attribute for the condition and that patient that I'm trying to treat. So for people, I will use probiotics as prokinetics.
Yeah.
For example, I'll use probiotics as an antimicrobial instead of having to use antibiotics, and in concert with the herbal medicines that I might be prescribing as antibacterials too, that I might choose my probiotic to help do that same action, but by a different synergistic mechanism.
Awesome. So before we get into more of kind of your process and, you know, how you evaluate patients and stuff with probiotics, I guess just some basic probiotic education for anyone who's not familiar. So a lot of people have the idea of the reseeding concept, right? And that's kind of now an older idea from what we've learned. So what, I guess, educate us on what are kind of the mechanisms of action that probiotics have, and, you know, do they reseed or not? Or is that just an outdated idea?
I think in general, it's an outdated idea, and it goes back to, you know, Elie Metchnikoff, who was the we might go the founder of the modern day probiotics, and that he was the researcher who isolated out bacteria in what we now call yogurt, and then promoted them for intestinal health and longevity, overall health. And his idea was that you could take this fermented milk that had these bacteria in it, which are yogurt making bacteria, so Streptococcus thermophilus and Lactobacillus delbrueckii, subspecies bulgaricus, and that they would stay in your gut forever and prevent the putrefaction of protein, and hence enhance your lifespan and your quality of life. So, you know, that goes back to the early 1900s, this idea that they would stay. Now, what we do have since then is a lot of consistent research data showing that's not the case, that probiotics, at least current generation ones based on lactobacilli and bifidobacteria, even Saccharomyces, and even the E. coli initial 1917 strain, you know, to give you a bit of a broad reflection of the literature, they don't stay in the gut. In the vast majority of studies, in the vast majority of patients, they are gone within 1 to 2 weeks of cessation. Sometimes, like the initial 1917 strain of E. coli, might persist in some people for weeks to months after cessation of use before it keeps petering out. And if you look really, really, really hard, you might find a study that showed, like there was a study published in the last few years looking at a strain of bifidobacteria, and I think it's AH1206. Don't necessarily quote me on that one because it's not commercially available, so it didn't stick in my head.
Yeah,
I still will because I can't use it. Where they did find that 30% of people were colonized by this strain even 6 months afterwards. Okay, but this is rare.
Yeah,
this is very rare. So you might argue it's a strain-dependent trait for the capacity to colonize longer term. Okay. Now, I don't necessarily think this will always be the case, in that there are researchers around the world developing novel probiotics that are to be more like poop pills that have, you know, Faecalibacterium, Akkermansia, you know, butyrate producing bacteria. So I think we will have future probiotics that do have this reseeding, recolonizing capacity. But the reality is the ones that you're using, like your listeners are using now, that are based on Lactobacilli bifidobacteria, they don't reseed. Yeah. They don't recolonize. And you can do this testing on patients, but to do a stool sample during when they're taking it, and then, you know, 2 or 4 weeks later when they stop taking it, and they won't. The number of bifidobacteria will go down pretty dramatically, or lactobacilli.
Makes sense. So they're more used right now as a, you know, as a medicine, as a support to help with a certain function that people are having issues with, right?
I think that's how they should be used, and that's what the research tells us. And I think there's still some people that are in that older mindset of, you know, recolonizing. Oh, your stool test shows you're low in lactobacilli. We'll give you this, you know, permanently stay in your gut. And we know that's not how they work. But we do have good data showing that different unique strains have different unique capacities and therapeutic effects, which means we just have to match it up. We have to do the research, find out what the strain is capable of doing, and then we match that to the patient presentation. Tell this is what you do, what I do in SIBO, of going, okay, well, if someone has a overgrowth of microbes, that's probably, you know, we know from looking at research data, we don't have this individual level data, or at least rarely streptococci or E. coli Klebsiella, then you might go, which probiotic strain do we have that has the capacity to inhibit the growth of those microbes?
Mhm.
And I might give that one. But if I know that dysmotility is part of their picture, then I'll use a probiotic strain that has data telling me that it works as a prokinetic.
Yeah.
And generally, that approach works well with patients.
Gotcha. So I guess now just diving into more of people with IBS or SIBO. So when in your treatment process, when you're evaluating your patients, do you usually recommend incorporating probiotics? Do you usually use them right away as a first-line treatment, or how do you go about that?
I generally would. Now there are difference in approach when you've got one of those extremely sensitive patients that reacts to everything, in which case I will introduce things one at a time, very low dose, and slowly build up towards therapeutic doses. So I do have patients that are like that, but then I've got my what I call like a normal SIBO patient where they're not intolerant to amines and salicylates and histamines, and the list goes on. In which case I give them probiotics, prebiotics, and herbs all at the very beginning. And it generally, the treatment outcome is generally very good in that situation. But on the people that are very sensitive, then we might go, as I said, very slowly, very low dose, and you slowly build up towards a therapeutic dose.
Gotcha. So I guess when you start that process, what is kind of the recommended amount of time to see if this probiotic and strain specifically is showing, no benefit or making someone worse and you need to make a change?
Yeah. And I suppose for my normal SIBO patients, I'm giving everything at once, and the results are pretty consistent and where I expect people to be at certain time points. So I generally don't see people react negatively to probiotics within that group. It might be the more sensitive people, and that we're doing one thing at a time and very slowly, and they may find sometimes it's a matter of sometimes it's just, you have to chat to the patients for a while, and because they may have had previously negative experiences with probiotics, but the probiotics they were taking are often generally quite different than what I would recommend, and they're often just those broad spectrum, high potency ones that have no research showing that they do anything specific, but which I think is problematic in a couple of senses, but. So you have to try to ease the nerves and the caution that they might actually have around that, and then again you start very slow and build up. But in terms of timeframes of when you might see them negative react, again that's very individual, and still some people, when you prescribe the right one, will be fine, and some people, I'm just trying to think of the most sensitive patients I've dealt with, or what time frames. They might react in the first day or 2 days or 3 days, depending on how super sensitive they are. But as I said, I think this, in the bigger picture of things, is actually quite rare.
Gotcha. So, and then let's say, you do have a sensitive case and someone's reacting, maybe they're getting more bloating, gas, maybe some brain fog, right? If someone kind of presents with symptoms like that when they start a probiotic that you've kind of decided may be helpful based on, the issue they're having, do you continue with that to see if it kind of normalizes, or, what's kind of what do you think if someone runs into that issue when they're trying something?
Yeah, I suppose for me, I'd try to take a step back and try to ascertain what the issue is, potential issues with those people, what they might be reacting to in that particular product, like whether it's actually the probiotic microbe itself, which I think sometimes it's not. Sometimes you're giving like I'll use the Lactobacillus reuteri DSM 17938 strain, which is in those little vial guy and those little drops. So I might go with 1 drop, and there's so insignificant amount of bacteria there that I have a hard time envisioning how that's causing a problem, because really there's more bacteria probably in their saliva that they're swallowing with a meal than there actually is in there. So trying to tease out what there might be, and that one is generally one that is well tolerated, I'd say, because you've got the capacity to start with low dose and it's an oil base. Whereas, as I said, other times there might be excipients and binders that someone might be more reactive to. Is it a die-off type situation? Is that what's causing their issues? Because certainly some probiotics, like that strain of butyride, does have the capacity to reduce levels of SIBO bugs or potential proteobacteria-based microbes in the small bowel or even in the colon, which could increase the release of endotoxins, which then could cause brain fog and other sort of symptoms. So again, I'd be trying to tease out what I think the main mechanism is and then how I could counter that and whether this was still the best tool for them.
Gotcha. So in sensitive patients, you were talking about how sometimes you do have to start with a little bit of a smaller dose. Is that correct? Yeah.
Yeah, for sure. I can think even looking at prebiotics like partially hydrolyzed guar gum, that typical person, they'll start off with a scoop or a tablespoon.
Yeah.
Typical SIBO person. Sensitive ones might be, extremely sensitive patients might be a pinch.
Yeah.
Day for a week and then slowly build up to a couple pinches. It can be much slower going.
Yeah. So bottom line is if you're a very sensitive patient, you're going to have to take things much slower and, very small. So when you're prescribing probiotics, how long is it best for someone to stay on a probiotic if they're having good benefits?
Yeah, I mean, for me, I use probiotics, as I said before, as potentially as antimicrobials or as prokinetics. So for me, they would be part of my maintenance strategy. So, for most people, you've got their treatment phase of SIBO, then you have a maintenance phase that persists for potentially many months afterwards. Yeah. In my practice, they would actually, the use of probiotics would persist. Yes, we'd have perhaps a different dose during the treatment phase or potentially even a different probiotic depending on the presentation, but then probiotics would be a core element of SIBO prevention in my practice.
Cool, gotcha. So I guess just diving a little bit into the brands and strains now that people, maybe it's good for them to be aware of. So as far as in the IBS and SIBO patients, we'll just kind of go through a couple of different points I have here. So like in diarrhea type patients, do you have any strains or types that come to mind that are usually good to try?
Yeah, I mean, I think broadly speaking, the Saccharomyces cerevisiae variety Boulardii biocodex material is the one that I would probably commonly see associated with diarrhea type SIBO, or be useful in the treatment thereof, I should say. Bacillus coagulans, and I have to remember this one, GB 1306086, which is a much more complicated name than most, has got some good research for diarrhea type IBS, which we know often is a decent surrogate for SIBO because they've got a higher percentage of people with SIBO within that particular grouping. But for me, it also goes back to the breath test results. And so I would generally treat SIBO when it's present on breath testing rather than empirically based on symptom picture. And then, because most people we know fit that pattern of, high methane equals slower gut transit time and constipation, and high hydrogen is diarrhea. Yeah. Most people fit that pattern, but some don't. And it's pretty crazy when you get a result of extremely high methane in someone with, doing 10 bowel movements a day. But I've seen it on at least 2 or 3 occasions in practice. So, it shows me that you can. It's best to do the breath testing, find out exactly what it is so you can target things a bit more, because there are some specific probiotics that can inhibit the growth of Methane smithii, the main methane producing bugs. So I would use that even if they were constipated or had diarrhea, if they're one of those few, if they had high methane production.
Okay, gotcha. Yeah, and that just shows how there's always outliers too, right? And yep. What comes to mind off of that too is, have you seen anything effective in cases where you suspect it's a hydrogen sulfide issue, right? It's kind of a big question too.
Yeah, it's I mean, I certainly treat people where hydrogen sulfide gas is a problem, and I've been treating people with colonic hydrogen sulfide gas issues for many years before people even postulating it being an issue in SIBO. And sadly, what we don't have is good data on herbs or probiotics to decrease, a level of hydrogen sulfide gas producing bacteria at this time point. But there is certainly data around broader changes to diet and prebiotics, for example, that can reduce levels of hydrogen sulfide gas producers in the colon. Now, you could extrapolate at least the dietary things to probably SIBO in terms of small intestinal growth of those same microbes, because many of those ones like Bilophila, for example, is a bile acid eating microbe, which is one of the main hydrogen sulfide gas producers. So any sort of dietary tweak you make that reduces bile acid output will actually reduce levels of that.
Interesting.
So that I certainly have results where you can do pre and post and see people's hydrogen sulfide gas producers in the colon go down, but because we don't have available testing at a clinic level to assess whether the small bowel microbes respond in the same way, it's hard to answer with any degree of certainty.
Okay, gotcha. And then kind of just going back to the probiotics that come to mind. So you were talking about for constipation type issues, there was a methane inhibiting strain. What was that one?
Yes, that's Lactobacillus reuteri DSM 17938. We know it decreases methane output. And we know that, and when we give it to people, they tend to do more stools and softer stools. So we see that, their transit time is sped up through that process too. And speaking of transit time, it's Bifidobacterium lactis HN019 is a strain that we know that speeds up gut transit time as well. And I've had some amazing results in, methane positive SIBO patients, or what I would call methane colonic overproducers, that they've got a lot of excess methane produced in their colon, not their small bowel, but in their colon, where just the addition of that strain has made a major difference. Nothing else to their quality of life and their bowel and their bowel transit time, their bowel pattern, and symptoms like bloating and distension as well. Really? But conversely, I had other patients where it's made very little difference. So it's not something that works for everybody, but it's certainly one that generally works well.
Gotcha. And then the one that you talked about for slow intestinal motility, that was the HN019 strain?
Yeah, that's right.
Cool. And then so I guess just based on brands, right? Like, so people maybe once they find a correct strain, does the brand matter, or is it more important that they've listed the strain that you're looking for?
Definitely the strain that matters most. And what we do know from market basket surveys where someone independent just buys probiotic products and sees whether they match, takes it to the micro lab and then see whether they match their label claims. The companies that choose well-researched strains in their products almost always meet their label claims, versus those that don't list their strain, we know around the world often don't meet their label claims. So I think that's a flag right there that those that delineate the strain have chosen that and made it specifically because of the research base that's there. And they generally have done a good job of making sure that bugs are viable at the point of consumption as well. Yes. So I think what's most important is finding the right strain for the task at hand.
Yeah. So if the company is smart enough and puts enough effort into actually labeling things specifically, it's most of the time it's going to be good.
Yeah, and that's what the market basket surveys show, that those that go through the effort and pay more for their suppliers to get those well-researched, clinically trialed strains, they do generally put them in the therapeutic mass, and they're there at the time when consumers eat them. But we know that conversely, there's a lot of companies that don't do that, use cheaper suppliers, and they don't always meet their label claims. That's clear from the data.
Yeah. One other question here based on the strains specific to people. So do you do anything for someone who maybe has issues with brain fog or the potential D-lactate acidosis issue, or, there's strains that don't produce D-lactic acid that you'll try, or does that not really even come up?
In my practice, it's never come up hugely. I think the D-lactate thing is blown out of proportion. Myself, I think it is an issue for a small percentage of people. I don't doubt that. That recent study that came out suggested it might be a bigger issue for certain SIBO patients. But if I think that's the case, and I had a patient in clinic just the other week where I think this might actually be a real D-lactate issue, I refer them for testing to confirm my suspicions before I take that approach, because endotoxins can cause brain fog and some of the same sort of symptoms. And if you sort of take away a whole set of therapeutic tools that could be useful based on a presumed diagnosis without confirmation, I think it does the patient a disservice. So I think, okay, let's see whether this is an issue. So, test to see the urinary D-lactate, the serum lactate, the serum acid-base balance, and see, okay, is this an issue in reality for you? Are you one of those people that do fit that criteria? And does that mean I'm not going to use a D-lactate containing probiotic in them? Not necessarily either, because if their D-lactate issue is because of an overgrowth of oral-derived streptococci, then using a probiotic that inhibits the growth of that streptococci, as well as herbs that do similar, makes total sense to me. So I'd still use them therapeutically. And the thing I've always found a bit of a mind bender here is that within 1 gram of poo, there is more bacteria that produce D-lactate than you're going to find in a capsule of probiotics.
Yeah.
So I've never quite understood this. I think it's been mostly a marketing ploy by certain companies more than research based. Yes, I do think it's an issue. D-lactate is an issue for some people, but I think in fact the linkage to probiotics I think is extremely tenuous, and even that study that was published by Rao et al., there's major issues with there, because I think when they actually looked in people's guts, they didn't have probiotic bacteria from supplements growing in their guts. They had bacteria from oral cavities growing in their small intestine, not lactobacilli, not bifidobacteria. So it doesn't even fit. That study is often quoted to support that argument, didn't, when you look at the actual data that they found, support that argument.
Got it. And then one last question about, I guess just maybe something that people may be confused about, or when they're trying a probiotic supplement. So what are your thoughts on, multiple strain probiotics? When you look at a multiple strain probiotic, is it important that each strain shows the amount of CFU? And I guess, how do you go about that? Because that's an interesting topic.
Yeah. For me, it's important that every strain that's included within a specific supplement has sufficient amounts to, in theory, have a therapeutic effect, and that's arguably a billion CFU, or quality forming unit, per strain. So if they don't list that and have 20 strains on the label, I generally won't go there. And for me, it's also that I want to know the exact strain that's there and matching that in. So you'll find that a lot of the well-researched strains can be available as single strain preparations, and they're probably less, but not always, less commonly available as multi-strain preparations. But often the same companies have done their research, and there's the cheap way of doing things, which is buying all your probiotic strains from the same supplier, whether they have any research on them or not. Maybe one's got research and they've got a cheaper range that has no research on it. So some companies will just buy all from there. Other companies will go, I want to make the best probiotic possible. I'm going to source, this probiotic strain from company A, this one from company C, this one from company D, and formulate like a really well thought out probiotic product that's been designed with thought, based on the research base. And those ones will generally have sufficient CFU dosing of each strain that's added in there.
Yeah. So, I mean, I don't know, for me, like, how does that multi-strain, because do bacteria compete when they're, together in a capsule, or how does it, it's just.
It's a great question. And if you speak to probiotic researchers on this, there is some concern over the combination of strains that have never been tested together before, and whether they're going to work in synergy or whether there might be some antagonism that's there. And we've got such little data on this that I'd say it's more in the realm of unknown at this point. But it is theoretically possible that you'd get better results. And to be honest, when I'm prescribing probiotics, if I'm prescribing 2 different probiotics, I'll get them to take them at separate times of the day, to limit the chances of a potential antagonism occurring. But in most cases, we just don't know whether there's going to really be synergy there. I think you can argue, but theoretic synergy, if they're having the same sort of target, but they have a different way of shifting that target, you'd expect there to be synergy in terms of mechanisms of action. But you're right, when they're floating around in your stomach and small bowel and colon together, are they competing for the same food source or producing compounds that inhibit the other, some of those things haven't really been teased out properly in most of those supplements.
Yeah, very cool. Awesome. So that kind of wraps up the interview, and I just really appreciate you coming on and, talking about your knowledge of probiotics. And I think it'll be really helpful for people to learn from this. So if someone's interested in learning more, from Probiotic Advisor or your courses, where can they find you online?
I think go to the Probiotic Advisor website. Sorry. And there we've got a number of online courses that people can do, including advanced probiotic prescribing and meet your microbiome, that's sort of based for the general public, as well as we have a range of courses for practitioners too. I think that's a good place to get a great in-depth knowledge about probiotics and be a much better informed consumer of probiotic products, which I think is important. Actually, I think it's important for clinicians to be upskilled in that area, but I think it's important for patients too, because I sadly can say that many clinicians aren't as upskilled in this area as they should be. From 18 years of teaching practitioners to be better prescribers of probiotics, that there's certainly a lot of progress has occurred in that time, but there's still practitioners out there that I think need a fair bit of upskilling. So if you as a patient can upskill, then you're in a better position to make an informed decision. That treatment of your body, which I think is important.
Yeah, and that's probioticadvisor.com, right? Correct. Cool. Yeah, and it's almost like we need kind of a materia medica, right, for probiotics based on every strain.
Yeah, very much so. And that essentially is what I developed, which is so I have an online course portal, but then I have an online searchable database, which is exactly that. So people can search what research has been done on the HN019 strain of Bifidobacterium lactis, what human studies have been done to date, what's it good for, and then you can also search for supplements. So someone says, hey, this supplement's great. You can go, okay, take brand A, type it in, and actually look at the research that's been done on the specific strains contained in that product. Because there are products out there that have a great research base, work fantastically well. Conversely, there are other probiotic products that have a good reputation, but absolutely no research base, and there are others that are sort of in between. So that searchable database allows people to tune into that materia medica to make that finding the right probiotic to treat the right condition easy.
Yeah, and I've used it myself. I enjoy searching in there and kind of just looking at the studies based on the conditions and the probiotic brands and everything. It's very cool.
I think so too. I enjoy it as well, and we're just in the midst of major updates. So I think we've got 300 new studies being summarized over the next 4 to 6 weeks. So it'll be interesting to see what the added data will be saying shortly.
Yeah, really cool. I mean, thanks so much for all your research and your passion, your interest in this topic. It's so great for other practitioners and patients as well to learn and to find evidence-based solutions that help them get their health back on track. So really appreciate it. Thanks for coming on.
You're very welcome, Josh.